Hello, this is Justin Bosnich. I will be presenting my signature assignment on erythropoietin, aka EPO. The chemical formula for EPO is C809, H1301, and 229O240S5. Molar mass is around 30 kilodaltons. EPO is a glycoprotein, a protein which contains oligosaccharide chains covalently attached to amino acid side chains. EPO has several distinct structures with 4 alpha helixes, 2 beta sheets, and 2 intrachain disulfide bridges. There are also 3 N-link polysaccharide groups and 1 O-link group. EPO is a very complex molecule comprised of polar and nonpolar segments. The polar components are water-soluble. EPO is not lipid-soluble. EPO is a hormone produced when the kidneys sense low oxygen levels in the blood. The production of EPO is done by the paratubule cells in the renal cortex of the kidneys. Once EPO is released, it heads towards the bone marrow where it binds to the erythropoietin receptors of the immature erythrocytes. In response, the JAK2 gene in the proerythroblast sends signals to the nucleus, resulting in maturation of the cell. The normal levels of EPO in the blood is between 4 and 26 millunits per milliliter. Normal ranges of EPO may vary depending on age, biological sex, and overall health. EPO levels exceeding 26 millunits per milliliter can create an excess of red blood cells called polycythemia. Polycythemia causes symptoms such as itchiness, numbness in extremities, unusual bleeding, painful swelling in one joint, shortness of breath when laying down, and pain in the upper abdomen caused by a large spleen. When EPO levels decline below 4 millunits per milliliter, red blood cell levels will also decline below normal levels, called anemia. Anemia symptoms include dizziness, tiredness, pale skin, shortness of breath, weakness, irregular heartbeat, cold hands and feet, chest pain, and headache. Usually, EPO is only measured after finding abnormal RBC levels. EPO levels are tested with blood samples taken via blood draws. If low EPO levels are present with anemia, the likely diagnoses are kidney-related, such as chronic kidney disease or damage to the kidneys from trauma or tumors. If high EPO levels are present with anemia, the diagnosis can be narrowed down to low level of iron and vitamins or a bone marrow disorder. If elevated levels of EPO and RBCs are present, the condition is secondary polycythemia. If RBC levels are high with low to normal levels of EPO, then the condition is primary polycythemia or polycythemia vera. Individuals with CKD and anemia-related bone marrow suppression or failure can be treated with a synthetic form of erythropoietin, rhEPO. The synthetic form of EPO is expensive, and some forms only stimulate the bone marrow for a few hours. These individuals can also be treated with blood transfusions. If individuals have polycythemia, the treatment for excess levels of RBCs is through phlebotomy, removal of blood, and medicines, chemotherapy, to suppress the bone marrow's RBC production. Synthetic EPO is a replacement for naturally produced EPO. rhEPO works the same way the natural form does by stimulating bone marrow to produce RBCs. rhEPO is produced through isolating the functional gene encoding human EPO, expressing the sequence in Chinese hamster ovary cells, and purifying the secreted rhEPO. Continuous erythropoietin receptor activator, SARA, is the latest form of rhEPO and is administered via subcutaneous, intravenous, and intraperitoneal routes. Depending on the individual, SARA should be administered once in 2 weeks to once a month, with each dose of about 0.6 to 1.2 micrograms per kilogram. Treatment with SARA will resolve the CKD-related anemia in about 6 weeks. Here are the references, and that is the end of my presentation.